We're going to focus on the lower cheek, mandibular angle, the lateral part, and the medial part of the mandible. So the mandibular contour, we're going to accentuate it. We're going to make sure that the light reflection of the cheek has a very clear demarcation to the neck. So there's the shadow line should become sharper. In the same time, as we know, while the mandible loses volume by bone resorption, there's an anterior migration of soft tissue during the aging process. And so while the lower cheek is moving anteriorly, the mandibular retaining ligament stops that movement and makes the soft tissue kind of prolapse over that mandibular retaining ligament. So what we're going to do is we're going to inject non-diluted calcium hydroxylapatite product, and we're going to try to give the observer the optic illusion of reduced bone resorption. So we're going to make sure that there's some, let's say, light reflection effect. Light reflection on the cheek, shadow below the mandible. Over here, I feel that there's the mandibular angle. So it's a little bit more anteriorly from where I have made that marking of the ideal position of the mandibular angle. And that's because during the aging process, there's an anterior movement of that mandibular angle. The danger zones in this area are, of course, the artery. There's the common and the external carotid artery. And the carotid artery goes in the deep plane, goes to the superficial temporal artery up there in the temple, and it goes medially and it crosses the mandible just in front of the masseter muscle over the bone and becomes the facial artery going up here. So both these arteries are deep. Another danger zone would be the parotid gland. The parotid gland is located subsmas and overlaying the masseter muscle. So if we stay subcutaneously, where we can give that nice sharpness, that definition, we are actually injecting in a relatively safe place. Of course, there is no such thing as a safe place in the face because arteries can be very variable, but relatively this is a very low risk area to inject. Then anterior to the jowl, you see we have the inferior jowl fat compartment where we should not inject, and of course the superior jowl fat compartment where we should not inject. So anterior to the jowl we can also give some volume over here and make sure that there's also an increased definition with non-diluted calcium hydroxylapatite. I'm going to make a pre-hole over here at the mandibular angle and at the pre-jowl sulcus. So it's basically two entry point cannula technique. For the definition, I will use non-diluted, and for the area in between, I will use diluted calcium hydroxylapatite. So basically, I'm using two versions of calcium hydroxylapatite, non-diluted and I think hyper-diluted would be good here. And either hyper-diluted or standard dilution could be used here. So practically it's easiest to use, let's say, for this type of skin, 1 ml of lidocaine with adrenaline mixed into a 1.5 ml syringe of calcium hydroxylapatite. All right, so we're gonna start with a little bit of local anesthesia. And so she has been previously disinfected, of course, but I'll just redo it. And I'll make a little blab of local anesthesia. 1, 2, 3. Here we go. Just a little blab of local over here, and a little blab of local at the pre-jowl sulcus entry point. 1, 2, 3. Okay. So I'll start with the non-diluted calcium hydroxylapatite. And I'll use a 25 gauge 38 millimeter cannula. And I'll stay in the subcutaneous plane. Of course, I've also disinfected the neck, because as you can see, the cannula is going to be pretty close to the skin of the neck, or even touching it. All right, so I'm here at the preauricular area in the subcutaneous plane, and I'll give a very nice and thick retrograde linear thread of about 0.2, maybe even 0.3 ml. At the angle, I'll just make tiny little retrogrades over here, just to make sure that there's a little bit of an accumulation of product at the angle where I want to have that angular appearance. Now I'm going to go to the anterior part, and I advance the cannula again at the dermal-subdermal junction, subcutaneously, bevel up, and I advance it until I reach that post-gel sulcus over here. Sometimes it's nice to use your fingers in order to minimize spread from the injected product. Make sure that it really remains a sharp line with a nice projection to the surface of the skin. And there's resistance. I use that rotation technique in order to pass it. And as you can see, maybe I'm even a little bit more superficial now. So in total, I'm injecting at least 0.3, but in this case, even I think 0.5 cc's, just to accentuate definition of the mandible. So let's see what it does with light reflection. Looking from the side, there's just a little bit missing over here, so I'm going to just go ahead and improve that result. So over here, I just move a little bit further, almost into the gel, but just lateral to it. I give not even 0.1 there, where I saw that there was a little bit less lacking, a little bit of sharpness. All right. So look. So right now you see that there's an increased border, actually, definition between the cheek area and the neck area, where there's a sharp shadow here and there's more light reflection to the cheek itself. So I'm going to move anteriorly now and go to the pre-gel sulcus entry point. I stay subcutaneous and I advance the cannula in the subcutaneous plane. Now I can go all the way to the midline. You see here the cannula tip is just below the dimple, and I start injecting, and when I get to the pre-gel sulcus I inject a bit more. So it's basically a retrograde. Just give just a tiny bit more because I'm looking at my results. So I've just injected 2 retrogrades in the same place. So it's basically 1 retrograde in total of about 0.2 or 0.3 non-diluted calcium hydroxylapatite. Just a tiny bit more. Okay. Now I'm just looking at my result, and what I think I should do, the last little bit of the syringe I would like to inject here at the mandibular angle. just dividing it into very short retrogrades. I'm going to come back with diluted calcium hydroxyapatite to inject more into the cheek itself in order to get that skin tightening and that contraction of the skin, and with that I hope, of course, to improve the definition even further. So just as a general comment on mandibular contouring, it is of course preferable to start with cheek augmentation, because if you do something to the cheek, it will affect, of course, the position of the soft tissue at the mandibular angle. So this would be the correct order of things, is to start at the cheek and then work your way down to the mandible. So I've diluted classic version of calcium hydroxyapatite with 1 cc of lidocaine with adrenaline. And I'm going to use that to tighten the skin. So I use the same entry point and I just go medial to where I started in the preauricular area, right there. I stay superficial, so I lift up the cheek in front of the cannula, and to make sure that the cannula stays superficial, I kind of lift the cheek with my non-dominant hand and then press down the syringe in order to push the cannula tip up to the surface. And so shouldn't go through the skin, but I want to get as close to the skin as possible because that's where I want to have the neocollagenesis effect. And so I inject approximately 0.05 to 0.1 per retrograde, and that's enough to stimulate the skin to start producing elastin, collagen, and whatnot. Okay, then I move anteriorly again, and then superficial, I will just do the same thing. I'll just go and start in the marionette line. Of course, this is not going to correct a fold because of the reduced viscosity, but it's going to improve skin quality. So it's going to make the skin more firm, reduce those little lines. And I can go even all the way up to the mental crease. All right. And the results of this last half syringe are going to be visible in about, 2 to 3 months, when I am going to assess the result. At least 3 months have to be in between the treatment and the assessment of the skin, because the skin quality improvement will take at least 3 months to be really visible, and it will improve beyond 3 months until like 6-7 months after treatment. Okay, let's evaluate. Over here, non-treated, you see there's more of a gradient, more of a gradual change from light reflection of the cheek to shadow of the neck. The treated side, you see a more dramatic shift from light to shadow. So there's a sharper definition of the mandible.